My name is John Mascarenhas. I am a professor of medicine at the Icahn School of Medicine here in New York City. I direct the Center of Excellence for Blood Cancers and Myeloid Disorders, and I lead the adult leukemia program. But my real passion and interest is in myeloproliferative neoplasms and translational research, trying to understand the biology of the diseases and helping translate that into effective therapies in the clinic.
Dr. Mascarenhas, from your perspective, what are the highlights so far this year in myelofibrosis research?
So, I think myelofibrosis research, so I've been in this field for about 20 years, and I've watched it go from a field where we had very little insight into the biology of the disease, which meant very little targeted or informed therapies, to the era of JAK inhibitors. The first being 2011 with ruxolitinib, then 2019 with fedratinib, 2022 with pacritinib, and then 2023 with momelotinib has really afforded us a significant advantage in trying to tailor the treatments for different patient niches to improve spleen and symptom benefit. And I do think that translates to a survival benefit in our patients with myelofibrosis. So outside of bone marrow transplant, really these treatments are not curing patients, but they are addressing certain aspects of the disease. What I'm most excited about is the new era, the next generation of approaches that we're seeing, and we have been seeing and will continue to see emerge. And these include combination therapy approaches up front, so taking those JAK inhibitors, the benefit they have, and trying to improve upon that with the addition of informed therapies, rational drugs that have preclinical evidence, meaning in the lab with cells from patients, with animals that are engineered to have myelofibrosis, so that when we take them into the clinic, we are more confident, more informed in our decision making, that we're not exposing patients to drugs that really don't have rationale.
What do these research advances mean for myelofibrosis patients?
Well, I think what we're seeing is a shift towards more combination therapy. So what I think it means for a patient is deeper responses from not just spleen and symptom, but what we're looking at very intently are biomarkers of disease modulation and disease response, hopefully disease course changes. So things like reductions in their driver mutation. These are gene mutations like JAK2, CALR, MIPL, reductions in inflammatory markers, reduction in bone marrow fibrosis in the bone marrow. All of these things suggest that we're really starting to modulate the disease in a more significant way. What we're trying to show is that that actually matters to a patient, that these findings actually translate to better progression-free survival, better overall survival. So I'm really enthusiastic and excited by what is happening now, because I do think it pays off. It's incremental benefits, but things that are now more targeted, like mutant CALR antibody approaches or BITE approaches to those patients who have this abnormal CALR protein expressed on the surface of the cell, transformative, or at least the potential to be. JAK2 selective inhibitors, really going after that mutant JAK2 in a very selective way, or a type 2 JAK2 inhibitor. Really the potential to have very molecularly defined targeted therapies that will hopefully get us much deeper responses, that patients will see even greater benefits, better improvements in symptom burden, spleen, but ultimately survival.